Here, let me add that.
Are we live? No. Are you good?
Yeah.
All right, to our guests who are joining us right now on Zoom, before we call the meeting to order, can you do me a favor and just by physically raising your hand, can you tell me whether or not you can hear me right now? And is it, if you can hear me, and then raise your hand again if it's clear? Is it clear? All right, perfect. Thank you. All right. Good morning. We will now call the meeting of the Executive Committee to order. I am Board President Michelle Owens. And so we will proceed with our agenda as is in front of you. The first will be a appearance by Dr. John, who we might know as Press Perry. Dr. Perry. You are muted. Just a second, we'll see. So you can hear me, but I can't hear you. Okay.
Perfect. No, now I can unmute. I'm not allowed to unmute myself, which is probably a prudent thing for the board to occasionally implement for things. Yeah, it's a privilege to be here.
Awesome. So why don't you tell the executive committee about your request, please?
Sure. So infertility, we are very considered one of the most underserved states in the country, and actually tied for third lowest for access to care. This is something where there are only 3 board certified reproductive endocrinologists in infertility, all in the city of Jackson and Greater Jackson. So and Flowood and Madison. And basically there's a very limited opportunity to get appropriate care in a reasonable way such that people are routinely traveling about 3-4 hours. The ability to sort of save on these commutes by allowing people to get ultrasounds, inseminations on site would be an enormous boon to their lives, their opportunities to conceive and build families in our great state. We have, of course, with us Amber. She is Ms. Hutchinson is a women's health nurse practitioner with experience in women's health, actually with experience with infertility before even coming to the state. And we were wanting her to be in the Gulfport Clinic so that many of the people on the coast and many who are not wanting to go also to Alabama, which has classically been the case given the controversies and complexity there, the ability ultimately to receive care in the state. This would be for essentials for fertility. This would be for counseling, for ultrasounds, for inseminations, for hysteroscopy, and of course would not involve the more advanced procedures, which would continue to be done in the Madison Clinic. I have been flying down there for year and a half, 2 years now, on a regular basis, and just the need and the volume is such that her being there on a daily basis will be a great support to the women down there and the families, as well as to me.
So, Dr. Perry, can you tell us a little bit about so you mentioned just overall what our state's access is like. What is the option, or what options are available for the people who are in the Gulfport area, the folks down on the coast?
Really, they are suboptimal. Again, there is one group out of Mobile that has had meaningful lawsuits, meaningful people sort of leaving their practice. This was the case that led to the Alabama judiciary decision for things where they had actually had people break into their office and destroy embryos. There is a meaningful dissatisfaction. And apart from that, it's a lot of OBGYNs who, though wonderful people, have had limited training in infertility. Again, if you look at the number of hours spent in a fertility clinic doing direct patient clinic care over the course of a residency. It usually amounts to 0.1, 0.2% of a physician's residency training. And again, very wonderful people, but very limited experience on a day-to-day basis and very limited resources, and the ability to have streamlined flow and expertise makes a world of difference. This is something we provide, and we currently have people routinely traveling 3, 4 hours to Madison to get care, but it just takes a toll on them. And they're people who sometimes have to decide not to have families because the toll is too great for the distance. And so, again, but there are, apart from the Mobile group, that is pretty much it for the Gulf area for those with subspecialty training.
And so your request is for an exception to the extended mileage rule for collaboration with Ms. Hutchinson. Can you tell us a little bit about what in particular, because a lot of reproductive endocrinology and infertility is procedurally based. So what exactly is the plan for the type of care, or what kind of practice would she primarily be providing? What services would she primarily provide?
Right. So the core services beyond counseling, and again, anything for which there is difficulty or complexity, obviously they could come up here for anything. But the core things, counseling, which we again routinely discuss patients in person as well as we could virtually, and a lot of our initial consults are done by Zoom anyway. But there's just something to that in person which makes a difference for patients. For ultrasound again, this is follicular monitoring to see how eggs are growing. And this is actually throughout much of the country, it's even done by nurses, let alone advanced practice providers. There's diagnostic ultrasound and hysteroscopy. Again, for hysteroscopy, this is something we do very well as a practice. I've actually been I'm past president of the Society of Reproductive Surgeons. I just taught a course on hysteroscopy at the Mississippi Alabama ACOG. I oversaw the postgraduate course for hysteroscopy training at our national conference last year, of which 1/4 of those participating were nurse practitioners. Again, I'm teaching international courses on it. And for instance, the average OB/GYN might do 2 in the office per year and about 20 to 30 in the operating room. Brittany Linton, our nurse practitioner in Jackson, does about 400 per year. And when we were at the course last year, she was actually outperforming many physicians. Physicians have excellent, phenomenal training, but I think also the mentorship and technology, which many don't have access to, make a world of difference. And Amber, when we were at the conference, I was talking about how Amber with us here in Madison has already done, her past 30 hysteroscopies vaginoscopically, and there's all these physicians who never been able to do that. She is already performing exceptionally well, but if there were any difficulty, of course, those patients, we'd just say, hey, we don't have to figure this out this day. Let's wait until Dr. Perry can do that evaluation. We have very few emergencies. And then, of course, the ability to process and analyze sperm and then to place it directly in the uterine cavity through insemination. This is actually a nursing level skill, not an advanced practice provider. Although it's not done in the state of Mississippi, it is done throughout much of the country by nurses for things.
Oh, thanks for that. So it will involve at least some like office hysteroscopy as well, as what you anticipate?
Diagnostic, not operative.
Okay.
And so diagnostic operative hysteroscopy, it's a 2.8 millimeter neurosurgical endoscope we use. It's small enough to go in the male bladder in the office without anesthesia. So if it can go in the guy's anatomy, most women can handle it fairly well. I would say most people don't need even Tylenol or Motrin. When we published a study on this, 90% of people had pain or discomfort less than that of a pap smear done the way we do it. And we often don't even have to dilate the cervix, which would be a normal. Transcervical procedures are normal for endometrial biopsy, many things routinely done by nurse practitioners. So again, this is very different from operative hysteroscopy. There is no analgesia or anesthesia planned for it. And it will be comparable to what's done for many people for bronchoscopy or nasal endoscopy and other procedures, which will be routinely performed.
So, Dr. Perry, you've actually been pretty humble about this. We know that as far as hysteroscopy, office hysteroscopy goes, you've actually been one of the, I guess, more modern pioneers of kind of advanced.
Thank you.
And so I think that's something that's just, I'm putting that out on the record just because you are a gift to the state in that regard. And that's something that a lot of people may not know. But the work that you've done in this area and the way that you've improved upon existing technology has been really meaningful for a lot of women. And I just wanted that to kind of be out there in the air as it pertains specifically to hysteroscopy. And at least for people to know that we got good folks here in Mississippi that are doing that work. Any questions?
And to supplement that, we actually have people flying from New York and California to get care here because of the level that we provide. And we're very proud of what we do as a state.
Questions? Anybody? I noticed that Ms. Hutchinson is a women's health nurse practitioner. We don't have the ability to train women's health nurse practitioners in Mississippi. So Amber, can you tell us a little bit about your background in training, where you got your skills from?
Yeah, so I graduated from the University of South Alabama in December. And over the last year from January to December, I was in clinicals. I did 90 hours of primary care with a family nurse practitioner in Picayune, Mississippi, which is where I live. And then I did, it was like 360 hours with a women's health nurse practitioner in Picayune, and then 90 hours at Audubon Fertility in New Orleans, and another 180 hours with a women's health nurse practitioner in Gulfport.
All right.
Yeah.
Anybody?
And it's been with us for 2
Yes,
months.
yes, I've been here since March, yes.
Awesome, fantastic.
Yeah.
Any other questions from any other executive committee members? All right. Dr. Cleveland, anything? Any other issues? Okay. All right. Well, at this point, I will entertain a motion.
Okay. Motion to accept their request.
So to grant the exception.
Mhm.
Is there a second?
Second.
Any further discussion on the issue? All in favor for granting the exception for the extended mile collaboration rule part 2630, please say aye.
Aye.
Any opposed or extensions? Perfect. Motion passes.
Okay.
Thank you. I really appreciate you all, and it's a privilege, and we look forward to doing great work to make the board and Mississippi proud.
Absolutely. Thank you so much
Thank you,
for
guys.
what you do.
Thank you.
All right, moving on to the next item. We have an appearance of Carly, is it Koenig? Or Koenig? Hold on, we're unmuting you, 1 second.
It's Koenig. You were right the first time.
Got it. Just want to make sure we got your name right.
Thank you.
So, Ms. Koenig, go ahead and tell the executive committee about your request and why you're here and who you have with you.
I have Dr. Hurt with me. She is my primary supervising physician. We work in the same office in Starkville, Mississippi in dermatology. And our request is just that my secondary supervising physician would be Dr. Bowler, who is our other clinic in Jackson. And so that's outside of the 70 miles. We're asking for this request just under the circumstances that Dr. Hurt goes on vacation a few times a year, that I would still be able to practice in the clinic when she is gone.
Yeah, thank you guys. Thank you to the board for kind of hearing us out. In a sort of similar way, dermatology is somewhat underserved in the Golden Triangle area. I'm actually the only dermatologist in Starkville currently. And so we
we've wanted to not have Carly kind of halted if I take a family trip or something like that. Where within our practice, Magnolia Dermatology, we have 3 locations, a Clinton, Jackson, and Starkville, and 3 MDs in like one in each clinic. But we share the same medical records. Dermatology is very visual. We have photos. Dr. Bowler and Dr. Davis are tremendously helpful and kind and caring and happy to help Carly with any difficult cases that she might come across. We did not plan to have her doing any kind of surgical procedures if I'm not in the building, but simple office-based procedures that she's very comfortable with, such as biopsies or liquid nitrogen, those kind of office-based procedures. So we appreciate y'all considering the fact that we don't have another dermatologist within 75 miles, but we do have 2 more that are roughly 120 miles, but still happy to help Carly with anything that she might run across. And I actually would be too, even if I'm on vacation, I'm happy to help her. But 99% of the time, we literally work across the room in the same hallway. So this is sort of just just occasionally through the year if I'm not in town.
Ms. Kank, tell me a little bit about your, how long have you been with this practice and your background?
So I graduated from Mississippi College in December. I spent a 5-week elective rotation with Dr. Hurt, and then I spent my 3-month clerkship, 5 weeks with Dr. Hurt, 5 weeks with Dr. Davis, and 4 weeks with Dr. Bowler. So I've been working with them since the end of January, but as a student, I spent 4 months here.
Any other questions, guys?
Okay, motion.
All right, if no further questions, then I'm willing to entertain a motion
I'll make the motion to request their,
to approve. it.
to grant their request for exception to 2615.
Second. All right, any further discussion on that? So it's all in favor for approving the request, say aye.
Aye.
And so that's unanimous. Perfect. All
Thank
right.
you, guys. We appreciate you so much.
Now this is the second time we're hearing a recurrent theme. There, especially when it comes to subspecialty care. I mean, we struggle even with meeting the needs for primary care, but with subspecialty care, it is such a gift to have subspecialists and their extenders available to provide care to our patients. And so thank you so much for what you're doing.
Thank you. We appreciate it very much.
All right.
Thank you.
All right, so next item on the agenda is appearance by Dr. Nancy Shannon, who is appearing with a collaborative nurse practitioner, Joshua Bryson.
Hello. Thank you very much for giving me and my colleagues, Mr. Bryson and our Mississippi healthcare attorney, Ms. Sherry Wade, the opportunity to meet with you this morning. We also are asking for an exception to the extended mileage collaboration. Mr. Bryson and I both work with Q Care Plus, which is a telehealth organization devoted to preventing and treating HIV and related STIs. We work exclusively through telehealth and are in most states in the country, and we have recently opened in Mississippi. We work as the telehealth arm of 340B organizations, which seek to provide care for underserved populations. And I live in Colorado. Mr. Bryson lives in Florida, and we would like to collaborate. This model has worked very well for us in this company in other states. For example, I collaborate with other APRNs in Louisiana and Arkansas, and through electronic health records and through essentially a Zoom meeting like we're doing now. That is how we have face-to-face meetings with the people with whom I collaborate. I'm easily able to review charts. I make myself available both through our platform. We use Microsoft Teams as a way of communication, as well as, of course, being available 24/7 by phone, messaging or calls, as is our backup physician, Dr. Chris Hall, who incidentally is an infectious disease specialist who has worked exclusively in HIV care for many years and was very influential in developing clinics in San Francisco. So we've got a lot of experience in our company with HIV care. Both Mr. Bryson and myself are certified by the American Academy of HIV Medicine. And not only have we implemented this model successfully, of this model of collaboration successfully within this company in other jurisdictions, but I've worked in this area for now 7 going on 8 years, and in another company was able to do that too. Our standards tend to be like, in terms of chart reviews and face-to-face meetings, tend to be more rigorous than jurisdictions require. And it's made for a very successful care of patients, and we have very happy patients who are getting care that they might not otherwise get. So that is why we request that we could have this collaboration.
So can you just tell the executive committee what your background is specifically, Dr. Shannon? You mentioned Dr. Hall as an infectious disease physician. Are you also infectious disease?
No, I'm not. I'm an internal medicine physician. And as you're probably all aware now, through the advances that has been made, except in the care of HIV patients, and particularly in the prevention of HIV, this has become, with the exception of complicated patients, this has become something that we in primary care are very able to do. And in addition to my internal medicine board certification, I am also certified, as I mentioned, by the American Academy of HIV Medicine.
And Mr. Bryson, I wanted to also give you an opportunity to speak. Can you start off though by just telling us a little bit about your background and your training as well, and how long you've been working in this capacity? But give me a second so I can make sure that you can unmute. I just see the red. Is he okay? He's good to be able to unmute. All right.
Good morning, everybody. Can you hear me okay?
We can hear you.
I re-muted myself because I'm just getting over being sick and I didn't want to be coughing in everybody's ear, so I apologize.
Okay.
So my background is I graduated from the University of Miami in 2021, going through the pandemic. But so I did a year of working as a hospitalist, and since July of 2022, I've been working with Q Care Plus. So I work right now out of 5 other states, and we're adding Mississippi to that I'll be able to provide care for these patients. And we provide HIV prevention medications. Like Dr. Shannon said, we also manage HIV care, and we give patients the option to perform testing at home as well as in person. And it helps with, the healthcare disparities that are for people that don't necessarily have access to do things and go to offices and see people in person. So it helps widen the accessibility for these patients, and able to treat their tests for STDs as well as treatment. And we work with specialty pharmacies as well, so they can mail patients medication instead of them necessarily having to go pick it up in person. So it just again, widens the opportunity for patients and gives them access which they might not normally have.
And so, how exactly and this can actually be answered by either of you. How are your patients identified?
I'm sorry, I missed the question.
I just was asking, how are your patients identified?
I'm not sure I understand, Dr. Shannon.
Yeah, I think, how do they find us? I believe, or how do we know who to care for? They
Okay.
either come to us directly through our website, or they are referred over from our 340B partners.
And we have an extensive marketing team which advertises on a lot of social media, as well as a lot of dating apps, where a majority of our clients and patients that we see use and utilize when they're seeking HIV prevention methods, as well as other STD methods and things. So a variety of different options are available for them to come and find us. And really, if you Google, HIV prevention or PrEP, which is widely, terminology known to our patients, then we're one of the first, if not the first, that pops up in a Google search.
Oh, so you guys actually do direct to consumer marketing as well? Okay.
Correct.
Any other questions of the executive committee?
Have Dr. Shannon, have you and Mr. Bryson been working together before?
The two of us have been working at the same company, but I have not yet had the pleasure of collaborating with Mr. Bryson. So I'm looking forward to this.
Okay, but yeah, so you share an electronic health record, and how often do you have that chart reviewed?
Well, the plan for Mississippi is to, well, of course, be available whenever an issue comes up. But on a routine basis, I review charts on a monthly basis I do be doing that with Mr. Bryson and for other providers in other states as well. And then we would meet either monthly for a while until we get to know each other better at a minimum, and then quarterly.
Right. I think, yeah. The Mississippi requirement is quarterly meeting.
Mm-hmm.
Yeah. Right.
And the chart check.
And the chart checks monthly. Yeah.
Yes,
Right.
and we actually, I'm sorry, I didn't mean to interrupt you.
No. Go ahead. You're probably going to say the same thing that I was going to say.
Oh, I was just going to say, since this has been a model that has been in place for a while. We actually have a rubric that we developed that we use when we review charts. Was the clinical care appropriate? Was the documentation complete, and so on and so forth. So we keep that in a file for each time of each month that the charts are reviewed. And then after I complete that, I would meet with a provider, and we talk it over, and of course then, particularly any challenging or particularly interesting cases at that time, or any time that they come up.
So Dr. Shannon, do you work with nurse practitioners as well as PAs?
Yes, I do.
How many nurse practitioners and PAs do you collaborate with?
Well, within the state of Mississippi, it would just be Mr. Bryson.
But I mean, nationwide.
Nationwide, about a half dozen.
And do you provide direct clinical care yourself?
Not at this time. I have had many years, until about the last year or so that I've been with Q Care Plus, of providing direct patient care in the prevention of HIV and other STIs, as well as the treatment of HIV through a different telehealth platform.
Okay, thank you.
Dr. Kennard, any questions?
I'm just curious. It's more a curiosity maybe than a question that matters. But the medications that you said that you can conveniently mail to patients, where's the source of those medications, and does that help with the cost to them? Is that passed on to them as a fee through your service, or how does the medication part work?
In terms of the specific pharmacy for the Mississippi patients, I believe that Mr. Bryson may be able to help me out with that. We use different pharmacies under the umbrella of the Avita pharmacy, or whichever pharmacy a patient prefers. If they want to pick it up at their local CVS, that's fine with us. But our care is delivered at no cost to the patient because of the affiliation with 340Bs. And we're also we have an entire group within our company devoted to working with Gilead, for example, in obtaining medications free of cost or very low cost. But the care is delivered without cost to the patient.
Right, and under the Affordable Care Act, the main medications for HIV prevention, Truvada, Descovy, are supposed to be covered under that plan. A lot of times, if patients have insurance, then one of those are usually covered under their plan. They don't have insurance, and we use with 340B programs and our collaborations with the community-based organizations and cost assistance programs to get the cost of the medications covered for them as well. As far as like antibiotics for STD treatments or HIV positive patients and their treatment, same kind of applies with or without insurance. We find the different methods to get their cost of their medications very affordable, if not free for them.
So here's one more question. As you mentioned treatment, because I think I was thinking kind of prophylaxis, but for your patients who are undergoing STD care, like, do you all how do you go about the referral process for patients? Say, for example, if you have a patient who is on HIV therapy, and say, for example, they end up developing a complication, like, is there ongoing, like, is it total care where you actually are not just monitoring, say, their counts, but also doing assessments for like some other like infectious processes and those kinds of things? And if you find something via telehealth, what's your process for the continuity of care, for passing that patient off to another entity to be able to address their more acute need?
So we have a specific requirement for our patients for those incidences, so that way the patient gets the most appropriate care for them. And so we do regular follow-ups with the patients and reassess, their health and their conditions and symptoms if any of those are arising. We have an HIV coordinator who helps to refer any referrals or collaborations that we need or to send the patients to, can help facilitate that, or we can do it, as providers to providers ourselves, depending on the patient's needs and whatnot.
We also ask that the patients have a primary care provider, and the handoffs the referrals that are given are all warm handoffs. So a patient is never kind of left to their own devices in terms of receiving care.
Anything further from our distinguished colleague?
Please excuse my ignorance, but could you tell me what a 340B is?
That's a complicated question, but it took me a while to understand how this all worked. 340B relates to a regulation in the federal government, and these organizations are all working to serve underserved communities, and they can deliver medications because of federal guidelines that requires pharmaceutical companies to provide the medications at a greatly discounted price. So that's essentially how this all works out, and why they're called 340Bs.
Thank you.
Anything further? There a motion?
Motion to close the general meeting. to consider going into executive session to deliberate further?
So, there's a motion to enter into closed session to determine whether to go into executive session. Is there a second?
Yes, second.
All right. All in favor?
Aye.
Aye. All right. So now we are in closed session. So move. Yep. So let's see.
You needed them.
Raise your hand if you can hear me. Okay, actually, the executive committee has gone into executive session within a few minutes. They'll come back out and announce their decision.
Are they with us? All right, so the executive committee is now out of executive session. And Dr. Kennard, our acting secretary, will provide the findings from executive session, the decision from executive session.
Thank you, Dr. Shannon and Mr. Bryson. The executive committee has voted to deny your current request and recommend that you follow up with Dr. Cleveland, our executive director, to discuss potential pathways for reapplication.
Thank you for letting us know your decision, and I'd appreciate a email or some form of communication in terms of how to reach Dr. Cleveland so that we can work out a different way.
We will get you that information.
Thank you very much.
Thank you all so much for your time and for your appearance. Great. At this time, I think we need to, in order to move on with our next item on the agenda, I would like to entertain a motion to close the meeting to consider whether to enter into executive session.
I move to close the meeting to consider whether to enter into executive session.
Second.
President, if I could, just so the record is clear, I've got some major errors on the sheet in front of you. Basis for going into executive session would be section 25-41-7-4D, which is to discuss the issues of appeal order with respect to an application for licensure, which is confidential pursuant to section 73-52-1. And I do apologize. Formally for that.
7352-11.
Yes.
Instead of 732561. We got it. The other part you had. That was right.
It was wrong.
The stuff down below on executive session part was right.
It was, but I wanted to make sure that those.
We got it.
I didn't do that.
I think we've updated it.
Apologize.
All right, so it's been moved and seconded that we close the meeting to consider whether to enter into executive session. All in favor?
Aye.
All right.
sound on. If anyone who is listening, the executive committee has entered into executive session and will return shortly.
Madam Secretary, Master Secretary.
That's good.
Okay, we are back out of executive session and Dr. Kennard will discuss the I guess it's not even a decision. We'll just discuss the ongoings or processes from executive session.
Yes, thank you. There's just general discussion about some concerns with the licensing application. No action was taken.
All right, thank you. So at this time, we can hear, I guess, our executive director's report.
Yes, ma'am.
Take it away.
So, continue to meet with the other health board, one of which is here today, preparing for the board meeting. And we all have a good relationship with each other. I continue to meet with the PHP monthly to discuss participants. This past 2 months for March and April, I met with 9 different licensees and regulatory compliance meetings. As y'all are aware, we attended the FSMB annual meeting. And then in March and April, I also continued to meet with legislature about different bills and our budget. The really good news that, as Jonathan sits back there and plays with the sound system, is that our new audio system is projected to be in place for the July board meeting. So we're hoping that actually happens. Sometimes promises are not kept, but we're hoping that they will be. I thought that going back to the FSMB meeting, I thought Mississippi had a really good FSMB annual meeting. And just to highlight a few of those things, we had 3 speakers on stage, Mississippi as a whole, Dr. Owens being one of them, myself being one of them, and Scott Hamilton from the PHP, from FSPHP was also up there. Shova Gaines won her election to the nominations committee, and I'll mention it again at the board meeting. And I was sworn in to the board of directors of FSMP. So I thought, little old Mississippi, we really shine. So that's my report.
Yeah, just to kind of piggyback on the FSMB experience, which was really, really good for our delegation this year. People knew who we were and were really surprised just of the number of people that we had, because I think when people think of Mississippi, they think that it's always just a couple of people here or there. And we had one of the larger delegations, which was really good. But I think one of the things that came out of it, even with the sessions that we were in, is just the importance of how much this work is dependent upon strong relationships with other agencies and other entities. And I just want to say that I think our executive director has led by example in that regard and been really good in most instances in fostering, and building, repairing, and like even expanding relationships from our board perspective. And that was something that I think has made our board stronger and has given us an opportunity to really be more relevant when we look at something national like the Federation. And a lot of our successes have been as a result of kind of building up and shoring up those relationships. And so I just wanted to at least take my hat off to Ken for his leadership in that regard. Because while we were well represented, that has been under your leadership and because of a lot of hard work on behalf of you and your team, because this staff at the Board of Medical Licensure is amazing. And just being able to get the right people on the bus and get the bus going in the right direction is everything. And I think you've just done a really solid job on that. I mean, even for some of those things where we see incremental growth, whether it's working with the legislature and other things, and just getting the word out about what we do and the way in which we do it. But that's really a testament to our leadership. So thanks so much to our leadership and to our phenomenal staff for the work that they've done to kind of help get us to that point. And we're just looking for more and greater. So you set the bar pretty high. So now I hope y'all ready to jump. All right, so is there anything from anybody else before we end this meeting and prepare for the full board meeting? All right, well, thanks so much, and this meeting is adjourned until we start the board meeting.
All right.